Welcome to the Deep Dive, your shortcut to being well-informed. Today we're taking a deep dive into some really specific high-yield stuff. It's all focused on two super common skin infections, cellulitis and erysipelas. Common, but sometimes quite tricky to pin down right.
That's absolutely right. We've been digging through these revision notes, the kind that are just packed with the crucial details you really need to get your head around quickly. And our goal today isn't just to, read them out. It's to really pull out the most important bits, make it stick, make it memorable, and help you properly understand what's going on with these conditions.
Yeah, think of this as us sitting down with that material together, highlighting the absolute must-knows, finding those little aha moments, and just getting it firmly lodged in your brain. So let's get started and unpack what we found on cellulitis and erysipelas.
Sounds good. Okay, first things first. Setting the stage. What exactly are we talking about here?
The material defines cellulitis pretty clearly. It's a bacterial infection, and it gets into the deeper layers of the skin and the tissues just underneath that. What you'll typically see is redness, swelling, warmth, and it's usually painful. It really likes the lower legs. That's classic, but honestly, it can pop up almost anywhere.
Okay, so cellulitis, think deep, think kind of spreading, diffuse maybe. How does erysipelas compare then? The notes differentiate them, don't they?
They do, and this difference is absolutely vital. Erysipelas is described as more superficial. It stays mainly in the dermis, the upper skin layer, and just the top bit of the subcutaneous tissue. And the absolute key difference, the one you really need for spotting it, is the border. Cellulitis tends to have these undefined sort of hazy borders. It just fades out. Erysipelas, that's got a classic, sharp, defined edge. Often it's raised, looks fiery red, and can be really quite sore.
Ah, okay, so that border is the big giveaway. Cellulitis is deep and fuzzy. Erysipelas is superficial and sharp. That's a brilliant way to remember it. Exactly. It's a great handle. And the material clarifies that they're both acute infections caused by bacteria, usually your Streptococcus or Staphylococcus species.
Perfect. Connects the what straight to the why.
Yeah.
So speaking of the why, let's talk about the culprits, the etiology. What did the notes say causes these infections?
Well, the usual suspects, as we just mentioned, are Streptococcus and Staphylococcus. They're opportunistic. They tend to get in through some kind of break in the skin. Could be a cut, a wound, even an insect bite. The material specifically flags that erysipelas is very commonly caused by Group A Streptococci. Others are less common for erysipelas.
Right, the usual suspects. But the material also mentioned some rarer bugs, didn't it? And those are often the ones that catch you out in exams.
They really are. And the notes do a great job linking them to specific, memorable scenarios. You've got influenza type B, if you see that, think kids, especially younger children. Then there's Pasteurella multocida, strongly linked to animal bites. That's a classic exam scenario, isn't it?
Yeah.
Cat bite, dog bite, cellulitis develops. Think Pasteurella.
Okay, animal bites, Pasteurella. Got it. What else?
Vibrio vulnificus. Think water exposure, maybe seawater, shellfish, that kind of thing. And another quite niche one, but memorable, Mycobacterium marinum. The clue is in the name marinum. Think aquarium keepers, fish tanks.
Ah, linking those rarer ones to a picture. Animal bites, fish tanks, water that makes so much sense. It really helps cement them rather than just being random names.
Totally. Associate the bug with the scenario, pets, water, fish tanks, makes recall much, much easier under pressure.
Okay, we know what they are, what causes them. Now, who's more likely to get these infections? Let's dig into the risk factors the material identified.
Yeah, the notes list quite a few factors that make someone more susceptible. I find it helps to group them mentally, makes the list less daunting. First off, if you've had cellulitis or erysipelas before, your risk goes up significantly.
Oh, really? That feels a bit unfair. You've already dealt with it, now you're more likely to get it again?
Tell me about it. It often relates to underlying lymphatic damage from the first episode. Then think about anything that weakens the body's defenses. So compromised immunity, diabetes is a big one, cancer, any kind of immunodeficiency. These all make it harder to fight off infection.
Okay, so previous history, weakened immune system.
Hmm.
What else?
Problems with circulation or fluid buildup are major players. Obesity is listed, think skin folds, creating moist environments, plus often slightly poorer circulation. Lymphedema, where fluid backs up, impairs the local immune response in that limb, and related to circulation. Venous insufficiency, problems with the veins in the legs, and peripheral vascular disease, basically poor blood flow.
So issues fighting the bugs and issues with clumping, almost getting immune cells there and fluid away.
That's a good way to put it. And then a really important category is anything that breaks down the skin barrier itself. Chronic skin conditions like eczema can create tiny entry points for bacteria. Recent surgery or any kind of trauma obviously creates a direct route in.
Makes sense. Any other groups?
Yeah, the material also lists some lifestyle and other factors. Things like injection drug use, which involves breaking the skin barrier repeatedly. Advanced age is a factor. Alcohol dependency. Other inflammatory skin conditions, insect bites again, and even pregnancy is mentioned as slightly increasing risk.
Wow, okay, it's quite a list. But grouping them like you did, had it before.
Yeah.
Immune system weak, circulation or fluid issues, skin barrier broken, other lifestyle stuff. That really helps organize it.
It really does. Makes it much more manageable to recall.
Okay, so let's say one of these bacteria gets past the skin barrier in someone who's susceptible. How does the infection actually unfold? What's the pathophysiology the material describes? Maybe focusing on cellulitis as the main example.
Right. The notes describe a fairly clear sequence. The bacteria invade. They get through that broken skin barrier. This immediately triggers an inflammatory response in those deeper tissues.
And the inflammation. That's what causes the redness and swelling we see.
Exactly. The material explains that the body reacts by dilating blood vessels in the area, making them more permeable, so fluid leaks out into the tissue. You get this buildup of inflammatory cells and fluid, and that's what causes those classic signs. The redness, the swelling, the warmth, and the pain. Because it's happening in those deeper layers, the edges aren't sharp, it's more spread out.
And the worry is always that it might not just stay local.
Precisely. The notes really emphasize its potential to spread. If it's not treated, the infection can track along the lymphatic vessels. That's when you might see those red streaks going up the limb, which is called lymphangitis. And potentially it can get into the bloodstream. That leads to septicemia, a systemic infection, which is obviously very serious. Understanding how it develops really clarifies why those signs appear and why prompt treatment is so important.
It really does hammer home why you can't just ignore it.
Uh,
Okay, this next bit is super important for anyone assessing a patient. The differential diagnosis. The material lists a whole load of things that can look like cellulitis. What are the absolute key ones we need to know from that list?
Yeah, this list is crucial because, let's face it, a red swollen leg could be lots of things. Obviously, Erysipelas is on there. It's a type of cellulitis, but remember those distinct features, especially the sharp border. But then you have things like deep vein thrombosis, a DVT. That's a blood clot, not an infection, but it causes leg pain and swelling. Very different management needed. Contact dermatitis, that's an allergic skin reaction. It can cause redness and swelling, but often it's much itchier, maybe bilateral.
And the really scary one. The one you absolutely cannot miss.
Necrotizing fasciitis.
Yep.
The notes list this, and it's the critical don't miss. This is that rapidly progressing infection that destroys tissue deep down, needs urgent surgery. A key differentiator the material hints at is often pain that seems way, way worse than what the skin looks like, especially early on. Pain out of proportion.
That extreme pain.
Yeah.
Big red flag. What else is on that mimic list?
Oh, there are quite a few others. Things like venous stasis dermatitis related to those vein problems we mentioned causes skin changes on the lower legs. Insect bites can cause local redness and swelling. Superficial thrombophlebitis, that's an inflamed vein just under the skin. Also varicose eczema, pyoderma gangrenosum, which is an inflammatory ulcer condition, not infection. Chronic venous insufficiency itself. Vasculitis, inflammation of blood vessels. Gout can cause a very red, swollen, painful joint, often the big toe. Septic arthritis or osteomyelitis infection in a joint or the bone underneath. Erythema nodosum, those tender lumps usually on the shins. Could even be a drug reaction. And a couple more really serious ones. Severe ischemia or compartment syndrome, lack of blood flow or dangerous pressure buildup, both emergencies. And even, rarely, cancer spreading to the skin called carcinoma erysipeloides. The material stresses that sorting through this needs a really good history, careful examination, and sometimes investigations are definitely needed.
Wow. That is a monster list of things that could be. How do you even start to keep them straight in your head?
I think grouping helps again. Is it maybe vascular, like a DVT or venous stasis? Is it inflammatory or allergic, like contact dermatitis or gout? Is it another infection, but deeper, like septic arthritis? Or is it something else entirely? Focusing on those key distinguishing features, the material implies, like, is the border sharp or diffuse? How bad is the pain? Are there other symptoms like itching or joint problems? How fast did it come on? That's how you start to narrow it down.
It really highlights that red and swollen doesn't automatically equal cellulitis. Okay, let's shift gears slightly. How common actually is this? What did the notes say about epidemiology?
The material states pretty clearly that cellulitis is common, very common in places like the UK, and it affects people of all ages. Interestingly, though, it does note that getting precise, detailed epidemiological data, like exact incidence rates, can be a bit tricky.
That's surprising for something seen so often.
I thought so too. But the notes do reiterate that factors like age, gender, and especially those underlying conditions, the risk factors we talked about, they definitely influence who is more likely to get it.
So the takeaway message is clear. Even if the exact numbers are fuzzy, you will encounter this condition frequently. Understanding it is essential. Which brings us neatly to, what does it actually look like when you see it? The clinical features.
Right, this is where we put it all together. For typical cellulitis, the material describes that spreading redness, the area feeling warm to touch, being tender or painful, and swelling. The skin itself might look a bit shiny or stretched. Patients might also feel generally unwell, fever, chills, malaise. Sometimes you might see blisters forming, or even small collections of pus, little abscesses. It's also common to find enlarged, tender lymph nodes draining that affected area. And as we said, classically, it's on a lower leg, usually just one side, and often the patient can tell you about a small cut or graze where maybe it all started.
Are there any specific signs mentioned in the material that should make you extra alert?
Yes, a couple of important ones are flagged. Seeing red lines tracking up the limb away from the main red area that suggests lymphangitis, meaning the infection is spreading along the lymphatic channels. And the other one is feeling a sort of crackling sensation under the skin when you press on it that's called crepitus. It could mean there's gas being produced by the bacteria, often anaerobes, and that's generally a more worrying sign. Needs quick attention.
Yikes, yeah, crepitus sounds concerning. How does the presentation of erysipelas differ, according to the material?
Erysipelas often crops up on the face, or sometimes the leg. If it's facial, the note suggests thinking about a possible source in the nose or throat. A key difference highlighted is that with erysipelas, those systemic symptoms feeling properly unwell, having chills, maybe a high fever, they can actually start before the skin lesion appears, sometimes a day or so before.
So feeling sick first, then the rash appears.
Often, yes. Then you get that characteristic skin lesion, a fiery red, firm, often quite painful plaque, and crucially, it has those very well-defined raised, sharp borders we keep mentioning. There's usually local swelling, tenderness, and warmth too. On the face, it can sometimes appear quite symmetrical, but on a limb, it's typically just one side. Those systemic symptoms might continue even once the rash is out. In more severe cases, the material mentions you could see blisters, little blood spots called petechiae, or even some tissue necrosis, though that's less common. It usually clears up within about 7 to 10 days, but the skin might peel or change color a bit as it resolves.
This is the really practical stuff, isn't it? Knowing what you're looking for when you're assessing someone, that border distinction and the timing of symptoms for erysipelas seem like really useful pointers. The material also touched on how it's diagnosed and when you'd think about sending someone into hospital.
It did, and it's quite clear. Diagnosis is usually clinical, based on the history you take and what you find when you examine the patient. Especially in primary care, you often don't need routine tests. But if someone needs hospital admission, especially if you're worried about subcutaneous, the infection getting into the blood, then yes, blood tests and blood cultures become important.
And those admission criteria, the notes pulled them from guidelines like Nice Lions, you said.
Yeah.
They feel like really key decision points for clinicians.
Absolutely vital decision points. The material suggests considering hospital admission for IV antibiotics if the cellulitis is classed as Aeron Class 3 or IV 6. These are severity scores, basically meaning moderate to severe infection with systemic signs. Also, if the cellulitis itself looks severe or seems to be worsening rapidly, if the patient themselves is particularly vulnerable, very young, elderly or frail, or immunocompromised, if there's significant underlying lymphedema in that limb, and a big one is location. If it's facial cellulitis or involves the area around the eye, periorbital cellulitis, then admission is usually warranted unless it's extremely mild.
Okay, that makes sense. So remembering those criteria, how bad is the infection itself? Things severe, worsening, Class 3. How vulnerable is the patient? Young, frail, immunosuppressed. Where is it? Face or eye? And are there complicating factors like lymphedema? That seems like a solid framework.
That's spot on, a really good way to recall them quickly.
So if the diagnosis is usually clinical, when do you actually need to order tests? What guidance did the material offer on investigations?
It reinforces that default position. Clinical diagnosis, no routine tests needed for straightforward cases. But it's specific about when you should think about tests. That's if the presentation is atypical, it just doesn't quite fit the usual picture. or if the patient is severely unwell systemically, or importantly, if it's not getting better despite what seems like appropriate treatment, so treatment failure.
Right. And in those situations, atypical, severe, not responding, what tests might be helpful?
The material mentions cultures, blood cultures if sepsis is suspected. Wound swabs or maybe a skin biopsy or aspiration from the edge of the lesion might be useful, especially if there's an obvious entry point, pus, or blisters to try and identify the specific bug. It notes that inflammatory markers like CRP are often elevated, but crucially, a normal CRP doesn't rule out cellulitis, so it's not definitive on its own. Imaging like X-rays, maybe even CT or MRI comes into play if you suspect something else is going on underneath, like a foreign body that triggered the infection, or if you're worried it might have spread to the bone, osteomyelitis. The notes also add that if there's obvious pus, like in an abscess, that should be cultured after it's been drained. And really importantly for recurrent cases, it advises checking for underlying causes like diabetes or immunodeficiency.
Got it. So the default is clinical judgment. Tests come in when things are murky, really severe, not improving, or you're digging deeper for why it keeps happening.
Exactly that. Clinical first, tests for the tricky or complicated situations.
Right. Once you're confident in the diagnosis, how do you actually manage it? What are the main goals and treatments outlined in the material?
The aims are pretty clear. 1, treat the infection itself. 2, relieve the patient's symptoms, the pain, the swelling. And 3, prevent any complications from developing. The absolute cornerstone of treatment is antibiotics. Either oral tablets or capsules for milder cases, or intravenous antibiotics given directly into a vein for more severe infections requiring hospital admission. Supportive care is also really important. Elevating the affected limb helps bring down the swelling. Warm compresses might feel soothing. Simple over-the-counter pain relief like paracetamol or ibuprofen can help with discomfort. Good general wound care and hygiene if there's an entry point. And, as we discussed, hospital admission for those severe cases meeting the criteria.
Okay, antibiotics are key. Does the material specify which ones are usually recommended?
Yes, it gives specific examples. Flucloxacillin is listed as the typical first-line choice for mild to moderate cellulitis in the UK, as it covers staph and strep well. If someone's allergic to penicillin, alternatives mentioned include clarithromycin or erythromycin, which is noted as an option in pregnancy, or doxycycline. For severe infections needing IV treatment, options listed include coamoxiclav, cefuroxime, clindamycin, or ceftriaxone. Obviously, local guidelines should always be checked.
Makes sense. What about other aspects of management mentioned? Anything else important?
Yeah, the material adds emphasis on things like ensuring the patient actually rests the affected limb as much as possible alongside elevation. It mentions that anti-inflammatory drugs like NSAIDs or sometimes even corticosteroids might potentially help reduce inflammation and speed up recovery in some cases, although their use can be a bit controversial and depends on the clinical picture. A really crucial point is to address any underlying factors you've identified. So if they have athlete's foot, tinea pedis, treat that. Manage venous insufficiency or ulcers. Ensure good skin care, like using emollients to keep the skin well hydrated and prevent cracking. Also thinking about tetanus risk if it started from a puncture wound. And it reiterates the referral criteria, knowing when to send someone for specialist input or hospital assessment if things are severe, worsening, or complicated.
So it's really a package deal. The antibiotic is vital, but
Yeah.
you also need the supportive care, fixing the underlying issues, and keeping a close eye on things, and follow-up is part of that.
Definitely. The material advises follow-up, typically around 7 days after starting antibiotics, maybe sooner if needed. You need to check they're actually taking the medication correctly, compliance, and crucially, see if the infection is responding. If there's no improvement or if it's getting worse, that's a trigger for hospital referral. The antibiotic course itself usually lasts for about 7 to 14 days in total.
Okay, so summarizing management. Identify and kill the bug with the right antibiotic. Support the body with rest, elevation, pain relief. Address the root causes like skin breaks or circulation issues, and make sure you follow up to ensure it's resolving.
That's a perfect summary. Kill the bug, support the body, fix the cause, check it worked.
So what's the typical outcome? The prognosis. And what are the potential complications we need to be aware of, the things that can go wrong?
Generally, the prognosis is good, provided it's treated appropriately and promptly. The material states most cases resolve well with antibiotics and that supportive care. Early diagnosis and starting treatment quickly are really key. Apparently, over 90% of people get better without even needing to go into hospital. And for those who are admitted and need IV antibiotics, that treatment is usually very effective too.
That's reassuring. So usually okay, but complications can happen.
Yes, and knowing these really underlines why prompt and effective treatment matters so much. The more common complications listed include things like an abscess forming a collection of pus needing drainage, tissue necrosis or gangrene where the skin or deeper tissue dies off, also thrombophlebitis, inflammation of the veins, and lymphangitis, inflammation of the lymph vessels. And sometimes, especially after recurrent episodes, people can be left with chronic leg swelling or lymphedema because the lymphatic drainage gets damaged.
Okay, those sound unpleasant enough. What about the less common but maybe more serious ones?
The material flags these as occurring in less than 1% of cases, but they're the really critical ones to have in the back of your mind. Necrotizing fasciitis gets another mention here as a potential complication. Also, osteomyelitis infection spreading to the bone. And compartment syndrome, that dangerous pressure buildup. Both of those are serious surgical emergencies. Less commonly still, the material mentions acute glomerulonephritis, a kidney problem that can sometimes follow strep infections, endocarditis infection of the heart valves, septicemia, that widespread bloodstream infection, which is life-threatening, and streptococcal toxic shock syndrome, a severe rapid illness caused by strep toxins, also life-threatening.
Wow. Okay, so while thankfully rare, that list of severe complications really drives home how a seemingly straightforward skin infection could potentially escalate if not managed properly and promptly.
Absolutely. It underscores the importance of getting the diagnosis right, including considering those mimics and knowing when to escalate care or investigate further.
Right. And finally, the material gave some advice on prevention, didn't it? Especially for people who unfortunately get recurrent episodes. What was the strategy there?
The main strategy highlighted is tackling those underlying predisposing conditions, the risk factors we discussed earlier. So actively treating things like athlete's foot, managing leg edema or venous issues, ensuring good diabetes control, keeping skin moisturized to prevent cracks, that sort of thing. Reducing the opportunities for bacteria to get in. The material also explicitly advises considering long-term, low-dose antibiotic prophylaxis for patients who are at high risk and have had recurrent episodes.
Giving antibiotics regularly just to prevent it coming back.
Yes, exactly. The specific ones mentioned are phenoxymethylpenicillin, penicillin V usually, or erythromycin if the person is allergic to penicillin. The notes make a really strong point here. Recurrent episodes cause a lot of problems for patients and cost the healthcare system, and this prophylactic approach can be effective at preventing further episodes, potentially even after just one previous episode, if the person is deemed high risk, for instance, if they have significant lymphedema.
That's actually a really important point. You might not need to wait for, say, 3 or 4 episodes before thinking about prevention in someone clearly at high risk.
Precisely. Prevention focuses on two things: fixing the underlying vulnerability as much as possible, and for those most prone to recurrence, using preventative antibiotics.
Okay, so I think we've really taken those revision notes apart now. We've covered cellulitis and erysipelas from the definitions and that crucial border difference right through the causes, risk factors, how it develops, all those tricky lookalikes, how to spot it, when to test, the management strategies, outcomes, those serious potential complications, and finally, prevention.
Yeah, hopefully breaking it down like this has made those key points much clearer and easier for you to remember. Keep in mind that border distinction, diffuse versus sharp. Remember those specific links for the rare causes: pets, water, fish tanks. Grouping those risk factors helps. And definitely remember those critical don't miss differentials like necrotizing fasciitis.
Absolutely. So based on everything we've just unpacked from this material, here's a final thought for you to chew on. We heard how common cellulitis is, but also how long that list of differential diagnoses is, including some really dangerous mimics. So how much should we rely purely on clinical experience, especially in primary care, versus maybe having a lower threshold for some basic investigations just to help rule out those critical alternatives? Where's that balance?
That is a genuinely challenging question, finding that balance in everyday practice.
Definitely something to think about. Now, if you are studying for the MSRA, don't forget to check out pastmsra.com.
And freemsra.com as well for more great resources covering topics just like this one.
Thanks so much for joining us for this deep dive.